I'm going to present some basic concepts on cost effectiveness analysis and methods. I imagine there is a mix of exposure among the people in this room to cost effectiveness, from very sophisticated to kind of know what it is, but no real familiarity. So I'll try to address that problem so everybody has a basic sense of what cost effectiveness analysis is and how to approach it. We will then have a hands-on workshop in which you'll have an opportunity to choose a cost effectiveness question that's of interest to you. So in your research area, I highly encourage collaboration. So if there are a couple of you or three of you who have a common interest, you might want to join forces for that part of the discussion. We will review what research questions might look like in the context of cost effectiveness analysis, what methods might look like, and we'll show you how to sketch out a tree as part of your project. And at the end, those who would like will have a chance to present their work to the assembled group, and we'll have a quick recap and closing. So the purpose of the workshop, as I mentioned, is that at the end of it, you go away with a basic understanding of CEA concepts and methods. You have a topic that you've chosen, and perhaps most important, that you feel you have a foundation to continue that work in collaboration with members of the team or on your own, but that you have the basis and confidence to apply cost effectiveness analysis to topics that are of interest to you. So what's the purpose of cost effectiveness analysis? I would say that in the conceptual framework in which cost effectiveness analysis resides, the concept which is closest to the heart of the enterprise is that of opportunity cost. Really simple, really profound idea. It's simply the idea that resources that are committed to one purpose are no longer available for another. In other words, the trade-offs are real. You can do one thing, but not another. And so in the cost effectiveness analytic enterprise, we want to measure opportunity cost. We want to quantify it and deal with it in a transparent and consistent way. So we want to assess the efficiency of available interventions to achieve agreed upon health goals. And there's just a couple, that are sort of illustrative of the kinds of questions that you might address with the cost effectiveness analysis. Does it make sense to do less frequent or more frequent screening? In other words, does the extra cost of doing more screening justify the potential extra benefit? Do mobile service delivery make more sense than delivering services in fixed facilities? More versus less intensive treatment? And so as I proceed in this talk, you might think about comparisons that are of interest to you. And in fact, if there are any people who already know what topic they might want to subject to a cost effectiveness analysis, just raise your hand. Just be interested to hear a few ideas that might be percolating. They don't have to be fully developed, but just any thoughts that you guys might have at this stage. Yes, sir.
We're looking at maybe implementing a surgical nurse manager in an OR in Ghana. We want to see whether that intervention would change costs for the OR as a whole.
So it's the introduction of a surgical nurse manager where there is now nobody in that position. Great, that could work. Right. Any other thoughts? Yeah.
In the field of mental health training, paraprofessionals provide proven, established psychotherapy and treat mental illness, and then trying to figure out whether or not the economic productivity of those treated people is higher after they get
Got it. Did everybody hear her? So correct me if I'm wrong. What I understood was the introduction of paramedical psychiatric or psychiatric staff to intervene with the population, and the question then is, do they do better with the paramedical versus the full professional, where one of the outcomes of interest is their future employability or productivity? Is that right?
That's So it's actually only paraprofessionals, and we're just measuring not only mental health outcome, but also economic productivity outcome. And we love to be able to show that economic productivity also is greater than the cost of implementing the intervention.
Got it. So you'd like to show that that it's actually, from a societal point of view, that you're actually generating savings. The increased productivity exceeds the cost of this extra support. Great. Others? Yeah.
One would be an intervention for rural heart failure patients. It's two different levels of a nurse-led intervention, which involves education and teaching them how to monitor their fluids and looking at the impact on their healthcare costs and hospitalization rates and mortality.
Okay, so another manpower example where auxiliary personnel are intervening with rural heart care patients, and you're measuring the benefit versus the cost of that. Is that reasonable summary?
Yeah.
Okay, good. Great. Any others, or I will? Yes, sir.
We don't have the funds yet to do it, but an e-reader approach to providing education, especially in HIV, to present the guidelines, how to diagnose and treat in very rural areas where there's no access to internet or other electronic equipment. How effective would that be, and cost effective versus workshops and extending more formal training?
So how would you know it was effective? What's the outcome of interest that you'd be measuring?
Well, that would be the question, probably comparing what people do, what they implement, and also what they learn in a more formal assessment, which could be like an exam on the e-reader, various periods. What do they remember? What are they actually doing when they have access to this compared to what they learn at a workshop, and we go back a year later, and what are they doing? What do they remember? What are they doing?
So this wouldn't lend itself to a standard cost effectiveness analysis because you're not going all the way to a health outcome or even a proxy for a health outcome. You're talking about sort of the level of mastery of the material.
And then
Is that-
implementation.
Right. So if you took it to implementation and could randomize patients to staff that had the e-reader versus staff who had the traditional, and then look at outcomes, that could work, right? And you compare the extra cost of the e-reader and look at the presumably better outcomes and see, yeah. Good. Okay, great examples. Thank you for that. So let's talk a little bit about another concept very much at the core of the cost effectiveness analysis approach. What we're interested in is measuring, quantifying the incremental cost per unit of health gained. So it could be a death averted, so averting a bad thing, or it could be a life year gained. And it's always for well-defined, specified interventions, and it's always comparative. We're always comparing one course of action versus another. Now, the other might be doing nothing, which sounds like it's not a course of action, but it is. The status quo, if it's no intervention, can be considered to be an option that you're evaluating against, again, some active intervention. So sometimes we talk about deaths averted, sometimes we talk about life years gained, and they're really sort of inverses of each other and are conceptually equivalent. So let's get even more specific. At the end of a cost effectiveness analysis, you end up with a number, maybe two numbers, a ratio. And we refer to this in the business as the ICER, the incremental cost effectiveness ratio, which is the change in cost or the difference in cost between the two outcomes you're considering divided by the difference in health outcomes. So the ICER is, for example, the cost of intervention A minus the cost of B divided by the difference in health benefit. And we're choosing life years right now. It doesn't have to be, but we're going to divide it by the life years associated with intervention A minus the life years associated with B. So here's a mistake that none of you would make, but some people, when they're beginning to get familiar with cost effectiveness analysis, a mistake is to think about the cost effectiveness ratio of an intervention by itself. Say, well, it costs whatever, $1,000, and the people who got that intervention lived 10 years, so that's my ratio. No, that's incorrect because there's no comparator. So if you were completing a results table like this one, what would the difference in cost be? Well, there isn't one because, as I say, you don't have more than one intervention, no difference in qualities, therefore you can't calculate an ICER. So we're going to take the ratio apart now and look at the numerator and then the denominator. The numerator consists of the net cost, that is to say the cost of the intervention or the program adjusted for resulting changes in medical care. So very often an intervention will avert future illness and therefore avert future medical care costs. So the net cost, again, is the cost of the intervention minus the cost of averted future medical care. The sign can go the other way. You can have increases in medical care costs as a result of a intervention. So it's adjusted for the resulting change in medical care costs. It is still comparative, A versus B, the net cost of A minus the net cost of B. The denominator, still the difference between A and B, but now we're talking about the health outcomes themselves, what we're really most interested in here. And they can be denominated in natural health events, like a new infection or a death averted. I'm calling infections and deaths natural phenomena. You can also have an unnatural or purely conceptual measure of health benefit, such as a DALY or a QALY. The great advantage of translating natural health outcomes into DALYs or QALYs is you now have a common metric by which you can assess disparate health outcomes like mortality and morbidity can be put on the same scale, and it makes it possible to compare on the same playing field, apples to apples, oranges to oranges, the results of different kinds of interventions. DALYs are bad. They're they're a disease burden, we want to avert them. QALYs are good. They represent gains in health. This can be a little confusing. So let's talk about DALYs because of the two metrics I just mentioned. In global health, you will most frequently encounter DALYs. Find QALYs sometimes, but as I say, most frequently DALYs, so let's talk about them for a minute. It stands for a disability adjusted life year. As I mentioned earlier, it's a summary of disease burden, and burden in turn can be thought of consisting of two parts. Mortality, that is the years lost to death that occurred earlier than it otherwise would have, and the morbidity side, or the illness side, multiplied by the duration of that illness and weighted by the severity of that disability on a scale that goes from 0 to 1. It has an opposite side from a sign from QALY. DALY is a negative thing, you want to avert them. QALYs are a positive thing, you want to increase them. It used to be that there was a major difference between DALYs and QALYs. DALYs had an extra feature to them. They had an age weight, which QALYs didn't. Age weights are out. And so now the difference between DALYs and QALYs, they do exist. A disability weight is measured and is a little bit different from a utility weight. We don't need to go into it now. I'm hoping that at some point we can call the whole thing off and just have one metric, make our lives a little bit make our lives just a little bit easier. Okay, so here comes the test. Okay, you guys ready for a quiz? So now we have two interventions, which is good. Remember, we have to have at least two interventions that we're evaluating. For no therapy, there's no change in cost. It's just the cost of the intervention, which is $10,000. There are three QALYs associated with that intervention, and there's no change in QALYs because we're just talking about no therapy and therefore no ICER. So what would the delta cost be associated with drug A? Yeah, $2,000. This is not a trick question. And then how about for the change in QALYs? So we're going from 3 to 3.5. Yes. And so the ICER, which is the change in cost divided by the change in QALY, what would that be? I know you're there. So again, I want to emphasize this concept of what we mean by the net cost. It's the cost of the intervention adjusted for healthcare costs. And here's the result of the simple arithmetic that we just did. So we have a result. This is the assessment of 2 interventions, change in cost, change in qualities, and the final cost effectiveness ratio. So now let's add another intervention. We're adding a drug B, and let's do the same exercise. What would be the value in that first question mark? 8,000. Sounds right to me. And what about the second question mark under the delta qualities?
Elliot, there were some people who said 10. You may want to explain why it's 8 and not 10 compared to the comparator.
I am going to explain in a little while emphatically why it is, but for the moment, I will simply say that we're comparing A with B, not B with no therapy, and I'll explain why later. It's a really good question. It comes up a lot. So going from A to B, we've got an increase in 8,000, and looking at the quality side, we're going from 3.5 to 3.25, which means the delta quality is?
-. Okay.
Right. And so again, if you do the math, you actually get a negative number. And so what we have here, if you look at the relationship between B and A, we find that B is both more expensive than A, and it generates less health benefit. So it's out of consideration. It is dominated because there's no trade-off. It's both more expensive and provides less health benefits. So there's no contest between A and B, and we don't even calculate the ICER itself. So anytime one option is both cheaper and better than the comparator, it's dominated by that comparator, and we don't calculate the ICER. Is that clear? Any questions? There's no end to the comparisons you can make. So now I've added a drug C and a drug D. Oh boy, I think there's a typo there. Where's drug B? Oh, maybe it wasn't a typo. Drug B is eliminated because it was dominated in the last slide. So now, when I add more options to be considered, I don't include the one that we already know is dominated, because we already know that A is superior to B. So now we're looking at C and D, and the point I want to make here is there's literally no limit to the numbers of options that you can compare if you array them right. So the costs need to be arrayed from least cost, different ways of doing it. But I strongly recommend, it's the most straightforward, array the options from the least costly to the most, then take the difference in costs and qualities between each adjoining intervention and calculate the ICER. No skipping is allowed. All feasible intermediate options must be evaluated. Let me provide an illustration in a totally different area, which may make it clear why that's true. Let's say you're in the market for a car. You're trying to decide whether you want to buy a car and also what kind of car you want to buy. Now imagine there's a world in which there's only one kind of car available. It's a Ferrari. It's a $100,000 car. It's either that or walk. And you might be in the position of saying, I really don't want to spend $100,000, but I really need to get to work. So I'll buy the Ferrari. I don't like it, but I'll buy it because that's the only choice I have. Now imagine you're in a world that has both Hondas and Ferraris. The choice is entirely different. It makes no sense not to consider the Honda. So in this world, you're likely to say, I get 90% of the utility of owning a car from having a Honda. It's reliable, it gets me from A to B. I'm not willing to pay the extra, $60,000 or whatever it is for the Ferrari just to, be in a cool car. And so evaluating, skipping a feasible, available option is like skipping a Honda when a Honda is there. Is that clear? Get that?
Good question.
Yeah,
On the last slide, was there a typo for drug D for the delta quality? Are you comparing A to D? That's what you're saying, C to D?
no, so I said drug C versus no therapy is inappropriate, right? Because that would be skipping.
But in
A.
the table,
Yeah,
I thought you were comparing everything to drug A.
no.
Okay.
Good, so let me go over it again.
So, oh, okay.
Each intervention is being compared with the next less expensive one.
All right.
So A is being compared to no therapy, okay? C is now a Ferrari. You're not comparing that with walking, which is no therapy. You're comparing it with the Honda, which is drug A.
Okay.
So you're, right, you don't want to skip an intermediate option that's available. So, and same with drug D, this result that it's dominated is only in comparison with drug C. Yeah,
So there's something about this that makes me a little bit uncomfortable, because if C was much more expensive than A, it could be $1 million for quality. And that would be your, so compared to A, it could be a really low utility for money, but it would be the best thing out there. And then if D comes along,
wait, hold it, why would it be the best thing out there? If C were really much more than $18,000, but still generated only one additional quality, then we have a terrible ICER.
right, but then so say you have C that has a terrible ICER, and then D that's, instead of being $1 million, it's, $1,001 per quality. Compared to C, it would look really attractive, but compared to A, it would still look terrible.
That's right.
But it seems like the way that this table is set up, you'd only be comparing it to the next most expensive thing.
In selecting, so in calculating the ICER, you're looking at it, you're comparing it to the next least expensive option. In deciding what you want to do, so now I'm a decision maker, and all I care about is cost effectiveness analysis. Okay? I look at this story and I say, it's drug A. Drug A allows you to buy qualities at the lowest price.
In his example though, would you ever, wouldn't you then take drug D and compare it to drug A just to see if there's, even if from drug A to drug C there's, a huge ICER, but then C to D is negative, would you then just compare A to D just to see if you had a better ICER from that perspective?
Let's work a numerical example at the end of this, and I think I can show you that it's actually not possible. Yeah. So sensitivity analyses, why should we be concerned with them, and what are they? So all cost effectiveness analyses have substantial uncertainties for a variety of reasons. One of them is that in most cases, the source of the data that you're using for your model and for the analysis was not generated for your cost effectiveness analysis. It was generated for, came out of an RCT or other effectiveness study, or even out of a meta-analysis. So you're getting data from disparate places. So you already know they're not, in many cases, they're not exactly the data that you'd want for your analysis. And there are other sources of uncertainty as well. So you could either sweep the uncertainty under the rug and pretend it's not there, not recommended, or you could deal with it in a systematic and transparent way, and that's what sensitivity analyses are all about. If things go well, one of the benefits of doing thorough sensitivity analyses is that you can convince your reader or your audience that your results are robust. So robust here means, listen, you could change the value of any input or multiple inputs to any plausible level, and it won't change the finding. The intervention will still be cost effective, or not cost effective, whatever the result is. But you can't always do that, but that's what you want to test with a sensitivity analysis. Sensitivity analyses also make clear how results respond to changes in input values. So you can tell which parts of your analysis are most responsive to uncertainty or changing values. And it can also have sort of the opposite effect, which is inputs that you thought might be driving the analysis and have a lot of uncertainty associated with them. You may have the pleasant surprise of finding that actually it doesn't make much difference, and that can be very reassuring both to you and to the audience that you want to persuade of your recommendations. And so just an admonishment at the bottom, this is not an extra add-on to an analysis. It's really central to it. A no cost effectiveness analysis is complete without a sensitivity analysis. So here's an example from some work I did on the cost effectiveness of screening for gestational diabetes. This is called a tornado diagram for reasons I think you can appreciate. The horizontal axis is the ICER. It's the net cost per DALY averted, denominated in international dollars. And the vertical axis lists the major inputs that drive the results. And so it turns out in this study that the cost of postpartum care for pregnant women who had gestational diabetes is the single biggest driver of the results. And you can see that varying the base case value of that postpartum care cost between 50 and 150% of its base case value results in substantial change in the cost effectiveness ratio from, just reading it off here, it looks like about $600 per DALY averted up to about $2,400 per DALY averted. And as you go down, the successive inputs have less influence on the result. And then I wanted to draw your attention to the initial screen cost, because in this area, people are really concerned about the cost of the screening test itself. That's the entry into gestational diabetes care, is the initial screening. And so a lot of concern about more expensive versus less expensive tests. This is an example of finding that, in fact, it's not a big driver of the final results when you take into account future costs of type 2 diabetes averted, the cost of postpartum care, et cetera. So we're talking, in a one-way sensitivity analysis, of which this is an example, we're varying the value of each input separately. We're holding everything else constant, and we're varying the cost of the initial screen test, for example, and looking at how that affects the cost effectiveness ratio. So there's information in that that's definitely well worth doing, but it's limited. Did you have a question?
No.
I do.
Oh, that's it.
So on the y-axis you have each input, is that what you said, to the intervention, the different components of the intervention?
These are the inputs into the cost effectiveness model that assesses the cost and benefits of gestational diabetes screening and
So
treatment.
for example, you have prevalence. Can you explain like how prevalence would be an input?
Prevalence is about halfway down. It's on the graph.
Right, but what does that mean to include like the prevalence? Of
Oh, the
something?
prevalence of gestational diabetes among the women that you're screening. So the higher the prevalence, the more cost effective the result's going to be, right? Because you get a greater yield of women who will benefit. You're not quote wasting as much on negatives. So one-way sensitivity analyses, very useful, but limited in that you're only seeing the effect on the ICER of changes in one variable at a time. There are programs that will allow you to assess the simultaneous uncertainty in all of the parameters in your model. So this is called a multi-way sensitivity analysis, and it yields a curve that shows the distribution of ICERs given randomly drawn values from all of the inputs at once after you've assigned a distribution to those values. So all the input values have an upper or lower bound and a distribution that you think is the best representation of the actual distribution of the values of those inputs. They're randomly selected, an ICER is calculated, and this exercise is then repeated as many times as you need. I ran this 20,000 times, and what you end up with is a confidence interval around the ICER. So in this case, we've got a 90% probability that the ICER is between $543 and roughly $4,000 per disability adjusted life year averted. So there are standards in cost effectiveness analysis.
Elliot, there's a question here.
Yeah.
Oh, sorry, really quick question. What programs are you using for your one-way and multi-way sensitivity analyses?
For many years, I used Crystal Ball, and then I switched over to At-Risk. And I prefer At-Risk, but I'm not, yeah. And what's nice about them is about both of those programs is they ride on top of Excel. They're add-ons to Excel, and pretty intuitive, pretty easy to use. There are others as well. So there are increasingly...
One more question.
Yeah.
Sorry, Matt. Here, Elliot. So the inputs that you selected, so you varied the sort of stochastically the inputs that you selected into the model, and then you looked at the distribution over many 20,000 times of the sort of value you end up with. So two questions about that. So first, are you calling that a 95% confidence interval?
I'm calling it a 90%. I mean, you can like literally, pull those dividers to any interval you want, but I took 90.
Yeah. Okay. Is that how do you the bounds that you set on what the values that go into it will obviously like influence what those confidence intervals are, right?
That's right, and so will the distribution that you select for each one of the inputs.
So how do you select the range? Because that comes with uncertainty as well, right?
It does. So if you have data from a trial, like effectiveness, information from a trial, or any other published confidence intervals, you use them. Otherwise, what do you think is plausible? So in this case, we didn't have anything from a trial, and I took 50 to 150% of the base case value. And you can argue with that. You said that's not enough, or it's too much. So at this point, we're in an area of using judgment, trying to be as inclusive of a wide range as possible without being silly about how wide it is. But you're pointing out an important point about the multi-way sensitivity analysis, which is there's a little bit of a black box aspect to it. I mean, you get this nice, curve here, which looks like it might mean something. And in most cases it does. But in addition to setting the ranges, which can be arbitrary, you rarely know what the distribution of those inputs are. So you sort of assume they're normal distributions, or often people use beta distributions because they don't have infinite tails, so that's kind of nice. What I've done in recognition, or to combat this black box aspect of multi-ways, is I'll use two different distributions. I'll use beta distributions, have a strong central tendency, and then I'll run the same thing on a uniform distribution, where I'm basically saying I'm completely agnostic about what it is. Of course, I'll get a wider confidence interval, but that's the kind of transparency that I think you need to go to if you want to be completely, yeah.
Should these technically be called confidence intervals, or are these more like credible intervals from Bayesian analysis?
I'm not sure what the answer to that question is. I'm calling it a confidence interval in the sense that there's you can have 90% confidence that the value would fall between those two values given the distribution.
I think can I just take a shot at that? I think
Sure.
it would be somewhat erroneous to call them Bayesian, because part of the issue is that we assume that the input parameters are not correlated. you can make assumptions about correlation if you have the data, but often these assume independence for the 30 variables that are going in. And so you lose a lot of your priors in the process of assuming that independence. It's kind of our best judgment assuming independence is that with 90% certainty the ICER lies between 500 and 4,000 is
Right.
the easiest way to say it.
I think that's right. It's also, incidentally, it's easy to set up it's easy to set up correlations within this model. Like, for example, it's likely that the cost, in this example, that the cost of type 2 diabetes for children is going to vary similarly with the cost of type 2 diabetes for mothers. It's just treatment of type 2 diabetes. One's going to be later than another. So I believe that I set a pretty high correlation between those two input parameters. But you should run it with and without the correlations, because that's based on sort of plausibility, but not on data. So I have up here this reference that's at the bottom, the CHEER's Consolidated Health Economic Evaluation Reporting Standards that was published by BMJ earlier this year. And it's a terrific set of guidelines for cost effectiveness analysis. So it includes much more than the points I mentioned here, but it's a terrific checklist. If you're thinking about the design of a cost effectiveness analysis, you want to make sure to include or address each of the issues that is raised. The U.S. Preventive Services Task Force also has a book that discusses reference cases for cost effectiveness analyses. So, among the features of a reference case would be clearly defined outcome measures, such as a cost per colleague gained or DALI averted. Societal perspective is recommended. Discounting recommended both for streams of future costs and benefits, or for streams of future expenses and also future health events. Clearly stated time horizon, clearly stated currency, price date, and any conversion. So you're saying this is 2011 US dollars, for example. And then inclusion of a sensitivity analysis. So in a little while, you will be thinking about your own cost effectiveness research questions. So I thought we would go through an example and look at how we could turn a cost effectiveness issue in global health into 3 research questions, and then look quickly at the methods for addressing each of those. So you're a minister of health in Zambia, and you're thinking about how to allocate your HIV budget. Adult male circumcision is now known to be very effective in reducing female-to-male transmission of HIV, and you're thinking about starting a mobile camp to reach adults in more remote parts of the country. So you want to answer 3 questions. What is the cost of delivering adult male circumcision for standardized number of clients, like 100? And if you were to deliver those services to 100 clients, how many infections and disability-adjusted life years could you expect to avert in that population? And then, because we're interested in secondary transmission, what happens if you extend the model out for 20 years and try to estimate averted downstream transmission? And then, given that numerator and that denominator, what would the incremental cost per DALI averted be in this population? So let's take each research question at a time and think about what the methods might be for answering it. So the first one concerns costs. And one approach would be to review program financial and services records. You want to look at expenditures, not budgets, right? Budgets, sort of aspirational expenditure records. much better reflects actual resources that were committed to, in this case, this mobile adult male circumcision camp. So you'd want to quantify all of the resources that were used for launching these camps, derive the costs associated with them, and then how many people were served by that expenditure of money. So that would be one approach to addressing the first part of the analysis, this first research question. The second one, how do we quantify the benefits of this mobile camp? So what we'd want to do is build a decision analysis model that takes into account the mobile circumcision camp and what would happen if there was not a mobile circumcision camp. Remember, I've been emphasizing that there needs to be a comparator. So the intervention is there is a camp and the comparator is no camp. And we're going to build a decision model that projects the costs and consequences of each of those two options. And then finally, we're going to calculate the ICER, which is really just putting the numerator together with the denominator, getting the net costs of the program, again, adjusted for any reductions in future medical care costs, and the dollars averted in the denominator, and that's the ICER. So really, once you've assembled the numerator and the denominator, then you've basically got it. Then you've got your ratio. You're a couple of short arithmetic steps away from your ratio. So I mentioned a decision analysis model, and I want to introduce you to sort of the most popular kinds of decision analysis models that you're likely to encounter. Very versatile, widely seen, pretty intuitive and easy to understand. And these are decision trees. And they portray the important costs and health outcomes associated with each evaluation under consideration. They incorporate the idea of expected value. That is, they project the consequences of activities and choices and assign probabilities to each of those outcomes, and then sum the probability times the value of the outcome for the intervention and for the comparator, and then compare those two. This will be clear when you see the tree itself. Each branch of the tree as a whole covers all of the options that are worth considering, all the ones that are relevant to the question at hand. So they're mutually exclusive and collectively exhaustive and total to 100%. So here's a sort of most basic kind of decision tree. The square indicates a decision. The round or the oval nodes designate chance. So there's no human intervention with the round ones, human intervention only with the square one. And the human intervention is, are we going to have a camp or not? The top half of the tree is what happens if there's no camp. And if there's no camp, from 100 men, 40% will be infected by HIV over their lifetime, and 60% will escape infection. However, if there is a male circumcision camp, the portion that gets infected drops to 20%. So the intervention is about 50% effective, which is in fact about what we find in Africa. And so we've got, in the case of the camp, 20% of the men becoming infected and 80% not. Notice that in each cases, the sum of the probabilities of the branches both total to 100%. Okay, let's add outcomes. So here, we're now saying, fine, we've got 40 people whose HIV infection is averted. That's 100 times 0.4. And we're going to avert, and there are going to be 7 DALYs due to each of these new infections. So this is 7 disability-adjusted life years lost because of the HIV infection. And now, let's see how we get to that 280. It's simply the product of the 100 men times the 40% chance of infection times the 7 DALYs per infection. And so again, this is what expected value is. It's the probability of each outcome times the value of that outcome. And exactly the same is true for the 140, but it's only 140, not 280, because there's a 50% lower probability of becoming infected. Any questions on this? Yeah?
Just a quick question. So I assume that 7 goes back to your calculation on question number 2, the research question number 2. How did you select the 20-year period there?
Oh, so I don't know the 7, I chose a 7 kind of randomly.
Okay.
But why 20 years? Because it's far enough. So here's, this is another issue where there's no hard and fast answer. 20 years takes into account the bulk of the epidemic effects, particularly when you consider that you're discounting those future effects. So anything that's happening after year 21 is it's going to have a pretty small effect on the total, right? Because you're deducting 3% from each year. So that's one answer. The other answer is, who knows what the world is going to be like in 20 years? There may be, a cure for HIV, right? So to sort of project the reality that we're faced with today and the health options that we have now out more than 20 years is really, it's staring into a crystal ball that none of us have. I mean, arguably 20 years is too long. And in fact, I've done analyses where I've gone out 10 years and then just for this reason, 20 years also, and compared the results. So let's add intervention costs. So now we have the cost of the male circumcision camp, which is $100 per person, showing up here in this column. And we have zeros there because there's no camp, so there's no cost for the camps. And the 2,000 and the 8,000, again, it's 100 times 0.2 times 100 is the 2,000, and again, 100 times 0.8 for the no infected men for 8,000. So even though they weren't infected, you're still paying for the circumcision, but they wouldn't have gotten infected, but you still need to pay the money. So we get a total camp cost of $100, and we've averted 140 DALIs. Right, so this is the same thing I showed you before, calculating expected value. So now we're adding medical care costs. The $6,000 that you see in the upper right is the lifetime discounted cost of antiretroviral treatment for men who become infected. And it's the same kind of multiplication, the $240,000, 100 men times the 40% chance of becoming infected times the $6,000 per infection. And finally, we get results. So summing the total cost, that is the cost of the camp plus the cost of the averted medical care for infected men for the camp and the no camp arm, we actually get a net savings of $110,000. So that the averted medical care cost greatly overwhelms the cost of the camp itself. So we get health benefits and cost savings. So this is another dominant outcome. So that brings to a completion the material I wanted to cover with you. And I'd now like to, well, before I go on, any last questions on what I presented? Yeah.
I know you arbitrarily chose 7 as a DALI, but how do you calculate a DALI?
So a DALI is if somebody, you look at the life expectancy that they would have had in the absence of the disease or whatever the bad thing is that's happened. And the number of years that they lost is the DALIs. And you weight that, so you take the number of years that are lost, and then you weight that by how much disability was associated with that, how sick they were, how unable they were to pursue their daily life. So there are weights that have been defined for a wide variety of conditions. And so the reason why the DALYs associated with HIV is relatively small in this case is we're assuming that they would have gotten access to antiretroviral treatment, or a large portion of them would have. This could be the weighted average of 80% who got treatment and 20% who didn't. So each one of these numbers, if you unpack it, there could be a complex calculation about again, how many got treatment and what was the efficacy of the treatment and like that. So we're just kind of, each one of these numbers sort of unpacks into a much more complex calculation. But the basic point here is that 7 DALYs is the number of years that were forfeit, or that they lost due to becoming infected.